talked about this before when we had our first practice EKG. Pericarditis is one of those things that you may see in your practice. It's just basically saying you have an inflammation of the outer layer of the heart. This may be caused by a lot of reasons. It may be viral, it may be bacterial, it may be post-surgical, just traumatic, lots of reasons for pericarditis. But keep in mind, it is one of those diagnoses seen that your job is going to be to rule out MI. And you have to at least be cognizant that you're not going to have an MI in every single lead at the same time. The only exception to that is if you have really bad balanced ischemia everywhere, and then you go do some coke or something, and then you have this massive cardiac demand that goes everywhere. And okay, theoretically you could tax everything, but 99% of the time that's not the case. This is someone who's walking and going, if I lean forward versus if I lean back, I feel better, or I can't sleep at night because I have to sit up and it feels better finally, or I can feel my heart beat with every single beat. These are the situations that happen when you have pericarditis. That's just a rubbing irritation. You might have a rub that you actually can hear when you oscillate the heart sounds. Pericardial effusion is not uncommon. That's basically your body's response to anything is to have a sympathetic effusion around it to say, hey, let's lubricate that. Constricted pericarditis would be a concern because if that's pushing it in with all that effusion, that can eventually lead to cardiac tamponade. And if you get cardiac tamponade, then obviously you're going to have an inability to squeeze and then relax fully, so you're not going to have good ejection on the heart, and then that could cause cardiac compromise to the point of death. So not good, but not as obvious an issue with pericarditis. Typically, pericarditis is not that big of a deal, but again, you want to make sure you get a good history to find out why they have it. This is not treated with the same medicines whatsoever. You're going to be using NSAIDs and colchicine and potentially steroids. However, they don't tend to work as well long term, and they have more of a rebound. So typically, NSAIDs are your friend. This is a nice picture showing in every single lead there is some level of ST elevation, and just keep in mind that you would have this person come in saying they have chest pain and they have ST elevation. So of course you're going to go, oh my gosh, send them to the cath lab. Well, that's kind of why we worry about making sure we read the entire EKG and not just jump to conclusions, because I looked at this and the first thing that jumped out at me was V2, V3. You go, oh my gosh, it's elevated. Send them to the cath lab. So, but the reality is you spend a little more time. You could have started anywhere and you'd have seen that they're elevated. So it's just one of those things that you got to get in the habit of making sure you don't over or under read an EKG. Dressler syndrome is a very specific type of pericarditis. The reason that's a big deal is because it's secondary to cardiac trauma, MI, or surgery. And when these happen, some people will have just this really thin serous fluid. And I will say that sometimes we see this immediately after cardiac surgery. I work in cardiothoracic surgery, and I would say that maybe 1 out of every 50 patients, they'll come back from the OR and they have a real thin serous fluid coming out of their chest. Now, I'll be the one to say that this is anecdotal to say that. Now, the actual numbers are 7% prevalence, but just keep in mind that it doesn't always delay quite as long as that 4 to 6 weeks. Sometimes it's more immediate, and we'll put people on the treatment for it, and they do respond very well to it, which is, again, steroids at the very worst, but we don't like to use anything as bad for bypasses as NSAIDs, so we are kind of limited to just colchicine, unfortunately. There are other options, but again, the point of this is not a pharmacology lecture. The concept of this is just be aware that these are the things you'll typically see with it. Fever, pleuritic pain, sometimes a friction rub or some effusion are not abnormal. And again, if you have chest tubes in post-surgery, they'll be putting out that thin serous fluid.